September 1st, 2021, and the district took it on itself. So I'm hoping to answer a few questions, hoping to dispel some concerns, and hoping to educate you a little bit about how EMS is delivered in ESD 11.
Can you hold that mic just a little?
A little closer, is that better? Okay. I can hear myself then. So a little bit about me. I've been involved in EMS for almost 30 years, about 29 years now. I've been doing things along the supervisory or management route for about 25 years, 29 years, in addition to providing street-level care as kind of a dual role. I'd have to say that here at ESD is probably the first time I haven't spent a significant amount of time on the ambulance, just by virtue of growing a service. So, master's prepared from the University of Maryland, Baltimore County Emergency Health Services. I'm a fellow of the American College of Paramedic Executives. It's a volunteer position that kind of oversees some of the management activities that go along in EMS management. I might slip, and you might be able to tell that I'm from New Jersey. I relocated down here as part of starting the service in 2021. January 6th, I was actually traveling and saw the to-do at the White House on the monitors as we were moving through the airport. My official first day was January 11th, and the mission during that time was to build an EMS service from the ground up. So that sounds kind of daunting, but to do it was absolutely daunting. And I will tell you that I worked with some of the best people I've ever met or worked with in order to make that happen. And we're going to talk about some of the nuances associated with that. I live in district, so the care delivery is important to me. It's important to me for several reasons, and there's several components of the care that we're going to talk about today, and why it's maybe a little different than how other services have delivered care historically in the area. I do have two girls. My youngest is 21, my oldest is 24, just about to turn 25. She's been bitten by the EMS bug. She's a nurse, and it's in the family. She does provide care on the street level up in New Jersey. She's also an intensive care nurse, and absolutely an inspiration. I wish she was here. So what's an ESD? This is a question that's come up both locally as well as nationally. What is an ESD? An ESD is, let me click and talk about it here, it's a political subdivision designed to provide emergency services. Now, ESDs come in three flavors, okay? You have ESDs that focus on fire only. You have ESDs that focus on fire and EMS, and then you have an ESD that focuses solely on EMS, and that's ESD 11. We span several fire ESDs within our coverage area, so we work closely with our first responder partners in order to deliver care in a timely manner. ESD 11 is the largest by population in the state of Texas. We compare ourselves to the size of the city of Atlanta. We're 177 square miles, and we encompass 700,000 people, give or take. So it's a responsibility, right? It's not a small undertaking. So some facts about us, right? We have a fleet of 40 ambulances. Now, that sounds like a lot, but ambulances all bought at the same time. So who's driven a car before? Yeah? So things go wrong, right? And when things go wrong with your car, you take it to the shop and get it fixed. But if something's wrong with the ambulance, well, we really can't take it to the shop and leave it there for a couple days. So we need spares to cover the responsibility of the district. So again, being new, we had the opportunity to purchase some of the top-of-the-line equipment, some of the new sciences that come out pre-hospitally to provide excellent level of care to our residents and community. We're about 274 staff members strong, and that's inclusive of care providers as well as administrative and financial folks. You good? So we're an evidence-based, patient-centric, employee-centric organization. Now those are a lot of words. What does that mean? What does that mean? That means that we work hard to eliminate any barriers that our providers have to providing high-quality care. What kind of barriers are those? So paramedics traditionally have had to do things like wash their truck, stop their truck. Now we do that for them. So a day in the life of a paramedic at ESD 11 is you pull in your personal vehicle, you walk over to the desk where we hand out your equipment, You step into an ambulance that's been washed and fully stocked and checked, and then you go out and provide care. We're going to talk about that provision of care, that care delivery, in a little bit more depth as we move on. So the idea is I don't want our providers to have to handle responsibilities that aren't at the top of their level of certification. They should be providing excellent care all the time. Why should a paramedic be the one washing a truck when we have people who can do that? I'd rather than being a paramedic. We handle about 60,000 calls annually. We transport about 37,000, give or take. Again, being a new service, we're still piecing together data, but by way of structure, the ESD has 5 board members. A couple of them are in the back. Wave your hands. Thanks for your support. They're elected officials every 4 years. They cycle through. We have an election coming up, as indicated earlier, in May. Please vote, it's important. So I'm the sole employee of the district directly. And then the other employees come up through me. So the board is my boss, and the other employees report to me directly through a table of organization. Working with the board has been a very good experience. The support that they offer and the guidance they provide has been a wonderful, wonderful partnership. And former board members who are in play when all this thing went down, again, very grateful for all you've done and your insight and your foresight into care delivery. So here's our mission. And our mission's a little bit different, right? We would never have a mission statement that says we want to provide adequate care. We kind of want to be okay. We're shooting for mediocre. That's not what we're about. We want to be a world-class healthcare provider. What does that mean in the pre-hospital setting? There are different accreditations that take place that verify that we've met standards. So one of those is CAS, C-A-A-S. And that's essentially a recognition of a high-quality provider. We're in process for that. We needed to have some time under our belt in order to apply for it, and we're starting to gain that time. One of the other accreditations, and we'll talk about this over the next couple of presentations, is the ACE accreditation, and that's an Accredited Center of Excellence. We handle 911 calls, we process those calls. That recognition identifies our accuracy in producing the right level of response for those calls. So we were accredited by the ACE board earlier this year, and very proud of that. Very proud of the communication folks that made that happen and the support that we received from the board in order to get that through. We also want to reduce the cost of healthcare in the community. And there's some creative ways to do that, and we're going to talk a little bit about those. You'll hear me talk about cheeseburgers, and I make it Texas and call it Whataburgers. So we'll talk about that a little bit later. The other thing we want to do is we want to show other organizations our strength and efficiency so they can learn from us. To date, we've had several organizations come down to see our operation and to see the efficiency in our care delivery model. Some of the technology, we've had folks, believe it or not, from New Jersey, other parts of Texas, parts from Maine. So that said, we're gaining some momentum. I look forward to talking a little bit more about that. So our purpose, we do one thing. We respond to 911 calls. And everything else is a supporting factor of that. That's what we do, okay? We have our response time metrics as prescribed by the board. Our priority 1, our highest priority, is a 10-minute response time, okay? Priority 2 and priority 3 is a 15-minute response time. Priority 4 is a 20-minute response time, low acuity. In other words, it's more of a non-emergent response, something probably shouldn't be seen in the ER. And we're going to work towards mitigating some of those responses in the future, because the idea is to provide the right care at the right time at the right cost. And for those of you who have a healthcare background or have been paying attention over the last couple of years, that's called the AAA. And that's what we strive to do. Familiar with? Yeah. So that's our goal. When we talk about our volume-driven deployment, those are big words, so we're going to break that down a little bit smaller. But at our peak, we're at 25 ambulances, and then we dip to 16 on slower hours. Now that sounds odd. Wait, something's not right there. We're gonna make it right. Okay. So one of the things that we talk about, and one of the things that our executive team uses to solve problems and to identify ways to navigate situations that we approach is this triangle. Now, I don't take credit for this. This comes from somebody named Jack Stout, who recently passed. But talk about fiduciary responsibility, we talk about quality and performance, and we talk about employee focused. So those are the lenses that we look through in order to solve problems. So let's say, okay, it's a Friday night, we may need to put on more ambulances. We may need to look to reduce that fiduciary responsibility by paying overtime to put more ambulances on, but that extends and expands the quality and performance side. Does that make sense? Okay, good. Our goal is to take care of our people so they can provide high quality care to you. That's the mission and that's our driving force in a lot of our design. Let's talk about funding, okay? We're a $42 million budget. 21 million comes from taxes. The other 21 million needs to come from revenue and billing, okay? And we'll talk a little bit about that. So ambulances, by virtue of the way they're structured in the federal government and the pay structure, is designed as a service. And that means they pay when we transport. Now, that doesn't mean we're running around kidnapping people and dragging them to the hospital. That's not our mission, that's not our model, okay? But understand something about the flaw in this. It's a transaction, right? So I show up in the ambulance to you, and I say, hey, we're gonna take you to the hospital, we're gonna bill your insurance company, and the overflow is gonna go towards you depending on your insurance carrier, so on and so forth, right? It's like going to the doctor, but different. But in the meantime, I'm over here waiting for somebody to call 911. Well, who pays for the time while I'm waiting? How does that get paid for? Because when you want that ambulance, you want it in a timely fashion. That's called the cost of readiness, okay? So when the ambulance isn't doing anything, it still needs to be funded, right? It still needs to be able to get paid for what it does, okay? The cost of an ambulance, ballpark, can range from $207 an hour down to $103 an hour. Why the difference? Why the difference? There's different shift structures, there's different levels of tiers of care that we provide, and we have our most expensive trucks and our least expensive trucks. And that's based on their schedule, and that's based on the makeup of the crew. So our least expensive crew are 2 basic EMTs, and they respond to the very low acuity calls, right? The P4s, exactly. So the idea is to make sure our paramedics are ready and available for any of the higher acuity emergencies. Does that make sense? I'd rather have a paramedic available for somebody having chest pain versus transporting somebody who's got a stomach ache or the sniffles to the hospital. And how do we make that happen? Well, let's talk about that. Oh, by the way, remember previous slide, the last bullet there was our average reimbursement is about $500, give or take. So make it work, right? Make it work. Some challenges there, right? So we're going to talk about some of the ways that we try to operate more efficiently and make sure that that works and that we're ready to respond, prepared to respond, educated to respond to any emergency the community may receive or may experience. So let's talk about our deployment strategy. This has been a point of contention. Historically in the area, the shifts are based on 24 hours. So you come to work for 24 hours and you're off for 72 hours. It's a fire department-based schedule. I'll ask my law enforcement partners in the back, how often do you work 24-hour shifts? I'm getting a look like 24-hour shifts don't happen, okay? And I'm going to talk a little bit about the difference between EMS and fire. Fire is station-based deployment, and they generally have a lower volume than an EMS service. At least that's the information that I've been given from fire departments. So what's that mean? What does that mean? Okay, 24-hour shifts, that means lower volume. That means that they can go to sleep in between calls, and that's good, right? They're ready to respond. Now, as an ambulance provider, we take care of people. Now, people, as evidenced by you being here, wake up and move around during the day. They go places, they do things, right? So the volume changes based on your behavior, right? Our call volume is based on human behavior. Buildings don't get up and go to work. They stay right where they are, which is why the fire department model makes a lot of sense for fire trucks. Buildings don't move, people do. And similar to the way the police departments work, the law enforcement folks work, they staff for people stuff, because they handle people things. Because people do people things, right? That's what they do. And that means, generally speaking, daylight hours into the early evenings, sometimes, believe it or not, Friday nights, Saturday nights, into the later hours of the night. So ready for the Whataburger? Okay. You guys are all familiar with Whataburger, right? Okay. So Whataburger's open 24 hours a day, 7 days a week, I believe, except for Christmas. Don't hold me to it, from New Jersey, okay? That said, if you were the manager of a Whataburger, would you make the same number of Whataburgers at noon as you would at midnight? Why? Volume drops, right? And there's cost associated with 100 cheeseburgers an hour when we're only consuming 5. Does that make sense? So efficiency as part of the deployment focus. So if you were to ask within the industry what our deployment model is like, we're a dynamically resourced system. In other words, we change the number of ambulances based on human behavior in order to be efficient, okay? Something else that we do is we use a hybrid model. Our 24-hour stations, we have 10 of them, cover the entire geography, actually about 98% of the geography, within 10 minutes. So those are our geographical trucks, okay? But as you can imagine, and again, as our law enforcement partners can attest to, volume is different from Creekside to 1960, right? There's a different amount of volume that's associated with the different areas based on population, based on a whole bunch of demographics, okay? So the idea is we want to predict where an emergency is going to happen and when it's going to happen. Temporal and geographic prediction. Well, how does that happen? We have a giant crystal ball that we look into. No, just kidding. What we do is we look at historical data. You know, what time are there a higher number of calls? Where are a higher number of calls? And what is their acuity? And then we try to put ambulances near them. Okay? And this is similar to a police department-based deployment in that they put police officers in higher areas of crime. Do they have a crystal ball? No, they have history, right? And as evidenced by what was discussed today, they identify areas of high crime. So we identify areas where we have acute emergencies. Where do you think we see a lot of emergencies? Give me a guess.
60 intersection.
Cyber station? Yeah. So population demographics play a lot into that. So do you think the volume is the same at 11 o'clock at night on a Friday at Cyber Station as it would be at West Rayford and Kirkendall at the same time? It's not, right? That's logical. Okay. One of the other things that we do for efficiency, we talked about the different type of ambulances and the costs. Those 24-hour trucks are about $207 an hour, give or take. Our basic trucks that handle our priority 4s cost about $103 an hour. Okay? If you were to look at our call volume, our higher volumes are our priority 1s and priority 2s, which is why we only staff 3 BLS trucks, because they handle that lower volume. The other thing that happens with the lower volume is they're not in dire need of emergency medical care from our perspective, as well as the ER's perspective. So when our ambulance gets to the ER, they handle other emergencies first, which causes our ambulance to what we call sit on the wall and wait for a bed, which takes them further out of service, takes further resources from the community. Does that make sense? Okay. So the metrics that we report on is our shoot time. In other words, from the time we get the call to the time that ambulance is moving. That's how long it takes you to get your butt in the seat and that ambulance start rolling. Okay? We measure our response time, and that's measured from first keystroke. All right, that's a confusing term. First keystroke is when that 911 call comes into our dispatch center, and our dispatcher hits the keyboard for the first time to enter that call. That's where our clock starts. Okay? Not when the call's dispatched, not when the ambulance starts moving, from when we get that call, because we're a system. And our excellence comes from communications as well as response, as well as quality, and all the other things that go into making up the service. So from first keystroke to arriving on scene is our response time metric. Okay? And we aim to hit that 85% of the time. Our call processing time, we're looking to keep under 1.5 minutes. And that call processing time is something, again, that's going to be talked about in one of the other lectures coming up. But there's a slew of questions. There's a slew of questions that allow us to make sure we're getting you the right level of care. And I can tell you, having sat at a console and taken 911 calls, people get frustrated with those questions. Just send an ambulance, just send an ambulance. That's all I want is an ambulance, right? But keep in mind, should you ever have the need to call 911 and talk to my communications folks, that ambulance is already going as soon as we have the address. Those questions are to fine-tune the response. So that's happening in 2 different places. They've already sent the ambulance, now they're asking me more questions to give the providers more information before they arrive. Does that make sense? I mean, there's 2 processes happening simultaneously. One of the big components, or one of the big conversations in the industry is the use of lights and sirens. Have you ever been passed by one of my ambulances running lights and sirens? Yeah? It's kind of a thing, right? They're loud, air horns, lights going everywhere. It's a lot. And there's a lot of studies out there that talk about what's called wake effect accidents. In other words, you see the ambulance and you jam on your brakes. What happens to the person behind you? You know, what happens to the person when you move off the road suddenly to get clear of the ambulance? Well, we're causing accidents, and we know that as an industry. So we work to reduce the use of lights and sirens. And if you remember back to the idea of trying to predict where those emergencies are, we're able to make that metric with the reduced use of lights and sirens. Again, with the concept of the culture of safety that we want to expand into the community. We don't want to put you at risk. We don't want to put you at risk if we don't have to, okay? One of the other metrics I'm very proud of is we go to the hospital lights and sirens less than 5% of the time. That means we're able to manage the situation with the providers, with the equipment, with the medications that we carry without having to put the public in jeopardy. So once we arrive, the emergency is over. Most of the time. Some are time sensitive. You know, traumas need surgeons. Strokes need stroke centers. Heart attacks need heart attack centers. Those are time sensitive emergencies and constitute the lights and sirens to the hospital. That said, when you get to the hospital, and we'll talk a little bit more about some of the finer points of the partnerships that we've created with the hospitals. But when you get to the hospital, okay, I'm going to digress for a second. My wife was an ER nurse for 25 years. Okay? She worked in high volume urban environments. So I can speak with some authority. She was also my first kiss in grade school, but we're not talking about that. So when you get to the hospital, having your specific medical emergency or injury, that nurse is just taking care of you, right? It's 1-to-1 in the hospital. No, they're taking care of 8, 10 other patients, right? You're ringing that call bell, nobody's coming. When you're in our ambulance, and I say our ambulance because they're ours. When I say our ambulance, when you're in our ambulance, you have 2 highly trained, competent providers focusing solely on you, okay? So that's a perspective you need to keep. Because when you get to the hospital, 8 other patients have that nurse's attention. Okay. So this is a little bit of what we do, okay? So this is a little bit of our analytics. If you look at this is the month of December, last year, and it looks at, it's kind of hard to see, but the red is a higher call volume. The green is a lower call volume. How many Whataburgers am I going to make for the red hours? How many Whataburgers should I make for the green hours? Right? If I look at, let's say, 11 a.m. on Saturday, 43 calls on average. Okay? Versus that same day at 6 in the morning, even better, 5 in the morning, 13 calls. Should I have the same number of resources ready? Seems irresponsible to do it that way. Okay? You look at our average response time, and that's the priorities, 8 minutes and 14 seconds. If we look at the month of December, I'll tell you our busiest day was Saturday, which is odd, because sometimes our busiest day, believe it or not, is on a Tuesday. And it makes no sense to me. I don't know what happens here. Might be a Texas thing, but for some reason Tuesday afternoons, we've had our highest call volume on a single Tuesday afternoon for 1 hour. Give you an idea, we normally process about 25 to 27 calls in our communication center during our higher volume hours. Between 3 and 4 on a specific Tuesday in January, we were hitting 50 and 60 calls an hour. So we were overwhelmed, right? We were busy, and a lot of our ambulances, as a result, were doing calls. So we called in our partners to help. Our partners from MCHD, our partners from Sci-Fair, from Emergency Corps, from ESD. We call them in to help when we need to. But we're not going to call them in unnecessarily because they have responsibilities to their community like we do, right? So some of the analytics we use, just to give you an idea of how we kind of sculpt our staffing to meet our need. It's a business model, right? Supply and demand. Some of our technology, this is a picture of what one of our dispatchers, we call them controllers, looks at all day. So that's multiple maps, as well as what we call a CAD, computer-aided dispatch, and then the predictive analytics of where we think our next call is going to be. Our coverage area is outlined in green, our stations are circles, and I know you can't see it, but what you indicate here is that at this moment in time, 94% of the district is covered in less than 10 minutes. So we just got a new medical director. Dr. Casey Patrick was our medical director when we started. Phenomenal guy. He was ambitious and driven and rode the ride to get a new ambulance service started. Now, if you don't know what a medical director does, they put their license on the line. They say, I'm endorsing you to provide this care. Then they write guidelines as to how they want that care delivered. But they're ultimately responsible. So, good morning, doctor. Would you mind putting your medical license on the line for a whole bunch of people you don't know and we can't test if you don't beforehand? That's a big ask. So we wrote protocols that were designed to focus care specifically in the way that he was comfortable providing care. Okay? He recently left us, went up to what he felt was where he was heir apparent with MCHD, and we got a new medical director. Dr. Sarah Frances McClure came on board November 6th, and she's our new medical director with a great background. I want to tell you a little bit about her. She actually worked as a paramedic for Emergency Corps a number of years back. She went on and got her medical license. Then she went and did an internship in EMS in San Antonio with the fire department. After that, she went up to Wyoming and practiced wilderness medicine. And then she's come full circle and come back to Northwest Harris County as our medical director. She's getting her feet wet. She sees some changes she wants to make. She's very bright and very energetic, and hopefully you'll have the opportunity to meet her. She'll be at our next board meeting, and if you'd like to attend, by all means. The board meeting is the 22nd? 4th? 23rd of the month. It's at 5 o'clock at our headquarters over on Stubner Airline Road. I would love to see some of you there. Welcome the new doctor. One of the things that she does do and she's passionate about is riding out. She'll get in the supervisor's vehicle, ride with the supervisor, get on an ambulance with a crew, and ride out and see what they do. And she's already identified some areas of change. We've identified a situation where some of these freestanding emergency departments that are advertising themselves as emergency departments aren't providing the care that they promised. And it's not necessarily their fault, but they have to have a contracted ambulance that takes their patients to a primary hospital where they can get the additional care that they may require. And believe it or not, and you may have heard this, the EMS industry is struggling with recruitment. There's just not enough paramedics to go around. So these other services are providing response times to the ERs, the freestanding ERs, which are greater than 30 minutes. So they say, no, that's unacceptable, we call 911. And that may or may not be the right use for us. Okay? It's difficult to justify taking a person from an emergency department to another emergency department. So those are some of the challenges that we face in trying to make us a more efficient service. So our medical direction, we can have a medical consult 24 hours a day, 7 days a week, 365 days a year. And what does that mean? That means when a paramedic gets on scene and they say, hey, this situation doesn't necessarily fit a specific guideline, or I have questions. I have a phone a friend. I can phone a friend and I talk to the clinical department. I talk to the medical director herself at times. She'll show up on scenes. So the support that the providers are given is, again, 24/7, 365. In addition to that, we have supervisors, a minimum of 2 supervisors on the road at all times that can respond to high acuity emergencies and provide assistance. So here it is, whole blood. Let's talk about it. Let's get it out there. It's a highly debated topic in EMS, okay? It's something that people talk about nationally, something that's talked about locally, and I want to talk to you all about it today, okay? One of the things, again, this is an evolution, this is an in-process discussion, was when we looked initially at whether we were going to provide whole blood, we looked at the cost versus benefit. The number of people that receive blood pre-hospitally in this area historically has been about 0.003%. Okay? So keep that in mind. I want you to balance that with the cost of a whole blood program, which to start up would be north of about $1 million, give or take, at least the information provided to me. How much do you think it costs to staff an ALS ambulance 24/7, 365? About 1.2 million. So we have to take an ambulance out in order to provide the service that affects a small population. Okay. We've established a door-to-operating protocol with Houston Northwest. So that means when we get into the ER, we bypass the emergency department and go right to an operating room. We don't see the doctor in the ER, we see a surgeon. And that's provided great outcomes. Local research was conducted by prior Chief Quality Officer and Dr. Patrick, and saw that the proximity to the trauma center, based on the studies that were out there, some of the literature that's out there, didn't warrant the cost to benefit. One of the things, and ask anybody who runs a blood drive, we have surplus of blood, right? We have too much blood. We're just giving it away, we don't need it, right? Who needs blood? Some trauma patients in the pre-hospital environment need blood, but more often than not, that needs to be given in the hospital. And there's a lot of reasons for that, as you can possibly imagine. Reactions, in the pre-hospital environment, we use an O negative, we would use an O negative, which is a universally compatible blood. That said, there's costs associated with that. Our medical director is of the belief that if we can provide a cost benefit and a zero waste program, that blood is something we'll talk about. Those, I think, are responsible comments. So, here's a study that was done in 2009. It's a little dated, re-updated in 2017. It talked about whole blood and the impact it makes in the pre-hospital environment with a transport time of 30 minutes or greater. Our average transport time is 17 minutes. Okay? So, in discussing whole blood from the ESD 11 global healthcare perspective, right now, the evidence doesn't support the cost versus benefit that's associated with a small number of percentage of folks that receive blood restored. In addition to the proximity of trauma centers. And our partnership with Lifelight. We've developed a relationship with Lifelight that historically had been strained. We've strengthened that relationship. We meet with them fairly regularly, and we do utilize them. So there was a study done by the University of Maryland a number of years back. It took the number of injuries across the first responder world and compared them. Guess who is the most injured first responder group? That would be us. You know, whether it's backs, whether it's injuries, whether it's getting hit by a car, whether it's helicopter crashes, plane crashes. These are things that impact the safety of providers. So when we talk about a helicopter, the last thing in the world, keep in mind, my daughter's a nurse and she's talked about doing flight. The last thing in the world I would want to do is have her in a helicopter that crashes for an emergency that didn't need a helicopter. Does that make sense? Yeah, there's some people out there that really put their lives on the line to get in that helicopter. And we personally feel, that if we're going to put them at risk, there better be a good reason. One of the other things that's associated with helicopters, and Lifelight has a very creative approach to this, is costs. And you'll see this in the newspaper. It was a big to-do about 4 years ago when people were getting $75,000 bills for a helicopter, which wasn't covered by insurance, only partially covered by insurance. So we try to, again, take a holistic approach to delivering care. Remember that triple aim? That's part of it, okay? And we still use helicopters. You know, we had a situation west of 249 where a child was hurt in an equestrian accident. The appropriate thing was to fly that patient downtown. We did. And those practices are still in place. We just need to take a more judicious approach to the use of helicopters for all the reasons we just talked about. So what are our challenges? Well, I told you about the funding. That's a challenge. We want to keep these ambulances fresh, new. We want to pay our providers a thriving wage. We don't want them to have to work multiple jobs. We want them to be able to be happy and content. So funding is a part of our challenge. And there's some solutions that are out there. We're pulling what levers we can to run an efficient service. There's recognition. EMS is not recognized as an essential service. In other words, we're not essential, we're kind of optional. And we're not optional when you want us, right? So we need to understand what it would take to make us an essential service. And recognition. We as an organization, we as an industry, we as a profession don't know who we are. And I'm going to tell you a little bit more about that. We're a 911 government-based EMS service. Okay. Have you seen the Acadian ambulances that drive around? So they're different models. Sometimes they do 911, but they're a private company. They're funded by their billing. They also do what's called interfacility transports, where they take a patient from a hospital to a rehab or to a long-term care. That's not 911 response, but it's still the same ambulance. So who are we? Are we the Acadian ambulance doing the interfacility? Are we the ESD 11 ambulance doing 911? We talk about EMS in a very broad, sweeping manner, but EMS is multifaceted. EMS has a lot of components. Aeromedical, long-distance aeromedical, critical care. These are all components of what makes up EMS as a whole. And I want to educate you in the sense that not all EMS is the same. The EMS that we provide is that 911 response, okay? But when you hear these things as they come up from lawmakers and now on the national stage, they're talking about EMS globally, which means interfacility, which means for-profit, okay? They're lumping this all together. So we have an identity crisis that we're trying to pull apart, we're trying to identify at a national level, so we can ensure that 911 response is parsed out and funded appropriately as an essential service. Does that make sense? Okay. That's my dog. That's Ziggy, hanging out in the back of the ambulance. And we're going to talk about your question right now.
Hold it.
Bruce. Okay.
I'm sorry, what did you say initially was your budget?
42 million?
Okay, I did some rudimentary figures here. You got 164 calls per day,
Give or take.
4 calls per truck.
Give or take.
And you said that you get about $500 per person. That comes out to $82,000 and $29 million a year. And you said your budget was what?
42.
So it looks like you only need about what, $11 million?
Well, yes and no. Here's the other part of that. In building this service, we took out loans. So there's a $5 million debt service that's associated with us on top of it.
Okay. The other thing, there is not a day that goes.
Bruce? Hi, Bruce.
Unfortunately, everybody knows me.
Uh-oh.
On top of that, I drive around a lot and constantly see ambulances, trucks going nowhere. They're just driving down the road. I've seen them sit in restaurants. So there's guys sitting on the front bumper eating at one of our famous gas restaurants. Gasoline, you get gas and food at the same time. Mm-hmm. Is that part of the deal with keeping yourselves out and about, or what?
So it's a great question. And I want to take you back to the idea of a hybrid system. So we have 10 trucks that live in stations, and the other 15 at peak move around based on volume. So they're designed to handle volume. They're going to the places where we anticipate our next call. So that's why you'll see them moving. And one of the frustrating points that our providers have is I want to run a call, I don't want to move back and forth waiting for a call. And that's a point of frustration. I've worked in a system like that, and it is a bit frustrating. But ideally, we minimize those moves. And as we get more mature and as we have more data, those moves will become less. From when we started till now, we reduced to about 65%.
Okay, the other thing I forgot to mention was, so you get a call.
Yes, sir.
They say, my father just fell down, cracked the back of his head, and he's bleeding profusely, my car doesn't work, I need an ambulance. Well, the ambulance gets there, because you're not gonna send a top-ranked ambulance. You would?
Yes, sir.
Well, at what point would you not?
When my father fell 5 days ago and his knee hurts.
Okay. Then you get there, and then that basic ambulance gets there and finds out, well, oh my God, he fell because he was shot through the window. Now what do you do?
We send a supervisor who can provide that ALS care, or we send an ALS unit, or the basic units are trained if their closest place to go for that care is the hospital, then they move. Does that make sense?
Yeah, just wondered. Okay. The only other thing I have is, who does your billing?
So we bill in-house. Ambulance billing is a bit of a nuanced service. Historically, I've come from hospital-based systems and they don't do it well. Our folks are specifically focused on the nuances of EMS billing, and there are some nuances.
Well, I have a friend of mine, Harris County, has been doing it for years.
Okay.
So I was just curious. Don't we have to call you?
Sure.
We get one call right now.
Okay. Thank you for your questions. I appreciate them. Good morning.
Good morning, my name's Katie, and this is my brother Doug.
Hi, Katie and Doug. I'm
This
Jamie.
is- Hi, Jamie.
Nice to meet you.
This is on the recognition line.
Yes, ma'am.
We've used your services twice in the
I'm
last
sorry?
2 years. We've used your services twice in the last 2 years. Doug had a stroke 2 years ago. You came and picked him up at the church where they recognized he had a stroke and took him to the hospital. I wasn't here that time. On September 11th, he had his first major epileptic seizure at 8:05 in the morning. He died. He just didn't come back, and he started losing. Anyway, I did CPR on him, brought him back while I was on the phone to the
Were
ambulance.
they talking through the CPR?
No, I've had the training.
Oh, okay.
So, but I had gotten him back to where he was breathing again. They came in at 8:35. He had his second seizure. They already had him hooked up to a monitor, and they saw that it was coming, and they prepared a syringe, jammed him with it, and it stopped the second one,
Good.
like that. Recognition. Thank you.
Thank you for that story, and sorry for the trials and tribulations. You know, it's difficult to be part of an ambulance service. You know, you say, hey, we want to do a good job, but in order for us to do a good job, somebody has to have the worst day of their life. Right?
Yeah.
Sir?
Just a quick question. Of the 25 trucks that you have, peak period, as well as the 16 that you routinely carry, are all of those ALS units?
All but 3, and the 3 BLS units are often in addition to what our peak load demand is based on. One of the things that we're learning, one of the things that we're parsing out, is what is the peak of our lower level calls, so we can better suit those BLS ambulances to those. The BLS ambulances went live in August of this year, so we're still evolving that fine-tuning that data. So 25, sometimes it's 28, okay? And sometimes that 25 includes 3 BLS ambulances.
Tell them it's basic and advanced.
Basic and advanced, thank you. And the difference between them is level of training and certain procedures that they can provide. I'm gonna tell you something that I've been criticized for in the past. So, ready? From my perspective, the immediate life-saving interventions are handled on a first responder, BLS, law enforcement component. They're there first, they beat us there. And you know what they can do? They can give that epi for the anaphylactic shock. They can give the Narcan for the overdose. They can start CPR. They can alleviate choking. Those are super time-sensitive emergencies, and they're trained to do that. The paramedics, we prevent death. We prevent deterioration. But that immediate life-saving skills, the paramedic starts with basic skills to save a life. Just like our first responders, just like our law enforcement component, just like a BLS truck. There's a question in the back, too.
Hi, my name is Wanda.
Hi, Wanda.
What's the average billing
I'm Jamie.
that you actually bill a customer?
So that's a complicated question. Our baseline charge is $2,400. And that sounds ludicrous, right? I mean, I tell you how many people pay $2,400. They don't. There's a fixed reimbursement. The majority of our patients are Medicare patients, and there's strict government rules around that. What can be billed beyond Medicare? So it's nowhere near $2,400 at the end of the day. If the $2,400 is the burden is put on, it's borne by the insurance agency 9 times out of 10. Our billing department practices what's called compassionate billing. So they work with patients who have trouble paying their bill to get it as far reduced as possible. Payment plans are always an option. So those things are the dirty side of EMS, right? I hate to talk about those things, but when you go to the doctor, there's a copay, right? When you see a specialist, there's a copay. When you go to the hospital, they charge you, right? So we're part of healthcare, and we have that same level of responsibility and that same level of expectation.
That's why I think I'll call my insurance company today and find out what they pay for.
So they're going to tell you a few things. They're going to tell you a few things. They're going to say, the ambulance is out of network. They're not in network. Okay? Yeah, that's crazy sounding, right?
Mm-hmm.
So let me talk a little bit about that. Out of network, in order for us to recoup the maximum amount of billed monies from an insurance company, we need to be out of network. Okay? In-network ambulances are those ambulances that are doing inter-facility transport. Like, for example, if I'm taking you from the hospital to a long-term care, the provider, the social worker, should reach out and find out which inter-facility transport company is covered by your insurance company. And should you ever find yourself in that position, by all means, ask the right questions. And if you have questions, call us. We're happy to help you navigate some of those things.
I have one other question.
Yes, ma'am.
You mentioned that you take the people to Memorial Northwest. Do you take everybody to Memorial Northwest?
Oh, goodness, no.
Or you can pick who you want to go to?
Hmm?
You get to pick where you
Yes,
want to
ma'am.
go? Okay.
The only time that'll be different is if you want to go to a hospital that's not a stroke center and you're having a stroke. If you want to go to a hospital that's not a chest pain or STEMI center and you're having a STEMI. Or if you had a traumatic event and you want to go to somewhere that's not a trauma center. Then we're going to say, hey, we need you to go here. We want you to go here. Here's your trauma centers. Here's your STEMI centers. Pick from one of those. Because again, we know the system and we want to make sure you get the definitive level of care. Does that make sense?
Yeah. Can you provide us with a list of the right questions to ask our insurance company?
Yes. And I can't do that right now, but I can get that to you.
Next month, can you bring it?
Yes, I will bring it. And
Or he can get it to me.
I can get it to you. And you can, well, and I'll leave my cards in the back if anybody wants to reach out for a question that may come up after the fact, or that may be something you don't want to ask in a public forum. Okay, good.
What do the commissioners do? You're governed 5 commissioners, and what kind of skill set are you looking for in a good commissioner that would help govern you?
So that's a good question, and I would think that I would love to defer to some of the commissioners, but I haven't prepared to put them on the spot. But I think that the commissioners play a vital role, and they offer insights and intelligence and knowledge that I don't have. Good business sense would be a great asset. Be able to predict some of the things that are happening in the market. Some of the insights that are beyond my understanding as far as insurance and things like that. The sense of support is very important, and the sense of having an open-minded approach. You saw some of the challenges. You saw some of the things we're trying to do. Some of the water we have to carry requires that support, requires an understanding of a creative deployment model. Does that answer your question? Thank you.
Thank you for explaining.
Good to see you, sir.
Thank you for explaining many things which most people just don't know what ESD is all about. I think you have done a great job the last few years. I think, our community can really be proud of what you have provided. The question I have is, what are the challenges, what you see, needs to be accomplished?
So, and not being from Texas, I don't necessarily have much more than a rudimentary understanding of how the tax base works in the system. If you were to ask me, Jamie, what is your ideal system? I would say, if we could be close to 90 to 95% tax funded and use billing for capital replenishment. Wait, did he just say raise taxes? Did he? He didn't say that, right? He did. but I want to turn that into what that really means, okay? So ESD 11, the average EMS-based tax in ESD 11 is about $125 a household for the year.
Wow.
Okay? So the idea, again, Jamie's world, not real, is if that tax rate went from 3 cents to 6 cents, we would be wholly funded, and the impact to the community would be $125 more a year. Well, that's terrible, that's ludicrous. Let me tell you the bonus, right? If we could get this to work out, nobody who lived in ESD 11 would be billed beyond their insurance. In other words, that bill, when you call your insurance company and say, we're going to cover $75 of that $2,000 bill, we take the $75 and do it. So that's Jamie's ideal world. But there's a whole bunch of things that need to happen in order for that to be a reality.
Who
Have you
else?
done a good study on that?
Yes,
Have
ma'am.
you done a really good study?
Yes,
on
ma'am.
that? That seems like-
It seems logical, right?
Yeah.
I mean, if I lived, well, I do live in the community, but if it were me in the community, I'd say yes. You know, because if I'm having that bad day and I'm the primary provider for my family, I don't want my family to be left with a bill. You know, I'd rather them be part of the community, pay into what we perceive as an essential service, and understand that no, those financial struggles aren't going to impact our ambulance service. You know, we have a sustainable model that's going to be here for generations to come. Sir?
Yes, you mentioned a $5 million loan payment. I'm sure part of that was your initial setup, buying ambulances and that sort of thing. Your ambulances are all still running since they're all kind of new. That's going to change after a while. How are you setting aside money to be able to buy new ambulances without taking more loans?
That's the plan, not to take more loans, right? So ambulances are a funny thing. Ambulances can be what's called remounted. Now what that means is we take the box off the back and replace the 450 chassis. We're a Ford 450 shop, we're gas engines, and that's the plan. It'll cost us less to do that. And what we do is we take money each year and set aside. You know, we look to about a $200,000 mark on the ambulances, and because of the different types of ambulances, different ambulances will reach that mark at different times, which will allow us to stagger the replenishment. Does that make sense? It's a challenge. My colleagues nationally say, what are you going to do with 40 ambulances you bought at the same time? But that's the answer.
Who else?
Oh, yeah, sure.
Okay.
I have a comment, first of all, very clearly presented. Thank you so much. Thank you for the information given the way that you did. With all of your background, when you came here, I guess a couple of questions. What was the first thing that you were most surprised about? And how, with you being involved in national kinds of things, trying not to be prejudiced here, how do you rate kind of where we're at? You know, my husband's way into sports, and so like, what would you put us? You know, top 25. You know, what would you and knowing that we probably have room for progression.
Absolutely. So I'm going to answer the second question first. We joined a group called Aim High. Now this is a group of EMS agencies similar to our deployment model throughout the country to try and compare apples to apples. So some of the systems that are associated with that are in Kansas City, Oklahoma City, Pinellas County, Florida, up in New York, on Long Island and into New York City, Southern California, Southern Canada. And we share data back and forth on a quarterly basis. So we just got our first data dump back from them about 2 months ago, and we were dab smack in the middle. Okay? So out of those agencies, we're north of the 50% mark, and none of those agencies are less than 25 years old. So we do have room to improve.
Using the same model? They're not less than 25 years old?
Yes.
Okay.
So that said, you know, there's a lot of history there. Some of those models have changed over the years. Some of them have worked towards that dynamic deployment. Some of them were started volunteers. So there's a lot of different backgrounds there. But if you were to just take the ones that have been in service for 10 years, 10 years, we still place north of the 50% mark. So I've been impressed by that. What surprised me about Florida? What surprised me about Texas? It feels like Florida sometimes.
You know where you're at.
It's okay, I was the CEO of Cypress Creek at the beginning. That said, what surprised me about Texas, y'all are really friendly. People are really friendly. And, you know, I've had the pleasure and privilege to work with some of the most talented folks in the industry. And the folks that work at ESD 11 are some of the most talented folks in the industry. I have a great team. You know, I stood up here and told you a little bit about myself and about our service, but our service is made up of a team. My executive team, my management team, they're the ones that are really driving the success. They're the ones that put their heart and soul into it. They show up on Thanksgiving Day and serve the crews food. They show up on Christmas Eve and make cakes and cookies, okay? And one of the things that we try to do is we try to create a positive culture. You know, what we found, the generational workforce wants to be part of something bigger. So we want to build that nurturing kind of environment. We want to draw people to our service. Hey, I can go work for Fred's ambulance service and make $5 more. Or I can say with ESD 11, you know, I make less money, but the people I work with, man, they're aces. Thank you for your questions.
The Tuesday problem in Texas is Monday Night Football.
Note to self. I'll check and see if it's football season specific. Good insight.
Yeah, Jamie, my question or my concern is how or are you overwhelmed coming from Jersey City, a town of 12 square miles versus 277? I don't know how many trucks you have and how many paramedics were you charged, but do you feel overwhelmed? I mean, or we have to be concerned the fact that this is a bigger job than maybe you wish to have?
So it's actually a smaller job. I was responsible for more than Jersey City, where I was. So I had the northern region of New Jersey. My population was a lot busier. It was a lot more condensed. 12 square miles, but if you were to count the vertical miles.
I understand, but it's still less than half of the population here.
Yeah, so no, I don't feel overwhelmed, to answer your question in short. Like I said, I have a wonderful team. We're getting good data collection. I have resources at a national level when things are, let me double check that. I'm not ashamed to reach out or scared to reach out to some of my colleagues and friends. Say, hey, listen, John Washington, what do you think of this deployment? I'm seeing an odd spike in volume here. What do you think about that? Is it worth putting a 4-hour truck up with administrative folks to cover that peak, or do you think it's an anomaly? Yeah, listen, I work for you.
What about giving to the community and involving with a host of programs in the schools, this kind of thing? Is ESD 11 planning or doing any of this?
We are. We're in schools quite often. We have an ambulance outside if anybody wants to see what it looks like inside. We visit schools, we visit churches, we are involved in the community. I think that as we mature, that part of us will get bigger. We do car seat checks. You know, we teach new parents how to put car seats in conjunction with Spring Fire. We are involved in the community, and that's one of our focuses, to give back. Another focus that we have coming out is working on those people that call 911 10, 12, 15, 20 times a week and don't need it. So we're trying to get them plugged into Harris County Public Health and get them the services that they require that we're not providing.
Last call. Here we go. You go, George.
You have a ride-along program?
Yes, sir. Absolutely. If you're interested in doing a ride-along, I'm happy to put you in the truck with one of our supervisors. One of the stipulations is we don't want you to be with the supervisor late at night because they get very busy. And we don't like, the job is a dangerous job at times, and we don't want to put people in harm's way. But if you'd like to do a ride-along, however long you'd like to ride along, please reach out to me. My information will be in the back, or you can go to the website and find me there. But by all means, if you'd like to.
Do you do a dispatch ride-along?
Yeah, absolutely. They don't go too fast, but you.
I'm Kelly Peterson. I work for State Rep Harless, and I did a ride-along last year, and it was one of the top experiences I've had in my life. I had no idea, and I recommend anybody who can do it to do it because it was such an eye-opening experience. It was fantastic.
So thank you, and I remember that ride along. That was fun.
It was amazing.
So in addition to riding with the supervisor, we'll show you the whole operation, from dispatch to logistics to billing if you want to see billing. They're kind of boring. They're cool people, but their job is kind of out of computer typing most of the time. But anything you want to see. Again, we're here for you as the community. If there's questions, if there's concerns, if there's curiosity, if you want to do a ride along, see how we do things, come by. Door's always open, literally. Well, most of the time.
So let's wrap it up. He'll be here for a few minutes after, and you can visit with him. Please give him a hand. So anybody who hasn't put their name on the sign-in sheet, especially those of you who are here the first time, do it so I can read it, pretty please. It was over by the door somewhere.
There are forms on the second table that you can pick up on election information. And we'll just sign it.
So anyway, thank you. Thank you to Tracy Evans, who gave us the idea for this program in the next 3, I think. And y'all have a great month. Thank you.
Picture of the young Marty.
Thank you.